Hi everyone, this is the pre-class PowerPoint for part 3 of circulatory function. We're going to finish up with the circulatory system today. We're going to talk about cardiac dysrhythmias, which you can tell from the term means that there's a bad or an abnormal rhythm of the heart, right? That's what dys means. Now, to understand cardiac dysrhythmias, we first need to review a little bit about the physiology of the conduction system. You remember that heart muscle, you see the red arrow pointing at heart muscle cells. The heart muscle cells are unique in that they can generate their own action potentials, which then trigger contraction of the heart muscles. Now, most heart muscle cells are capable of generating their own action potentials, but there are certain ones that are modified so that they can do that at a faster rate. And because of that, those cells usually control the rhythm of the heart, and we know them as the heart's conduction system. Now, the heart essentially has two separate conduction systems. One, which is the SA node, controls atrial activity, and then we have the Purkinje system, which controls ventricular activity, and then there's the AV node that sort of connects those two systems together. Let's talk about the SA node first. SA stands for sinoatrial. This node controls atrial activity. It has the fastest intrinsic rate of firing. You can see the SA node fires at about 60 to 100 beats per minute, so normally it serves as the pacemaker of the heart. The AV node, which we said was the part of the conduction system that connects the atrial and the ventricular conduction systems, usually is the only connection between those systems. So if transmission through the AV node is blocked, then you're going to see the atria and the ventricles totally doing their own separate thing, beating independently of each other. Now, the thing that's sort of interesting about the AV node is that once the SA node generates an impulse, it travels through the conduction pathways very quickly till it gets to the AV node. And once that impulse gets to the AV node, there's a little pause or a slight delay before that impulse is then conducted through to the ventricular system. What do you suppose is the purpose of that slight delay in the conduction of the impulse through to the ventricles? Okay, the delay is to allow time for the atria to finish contracting, emptying its blood into the ventricles so that the ventricles are nice and full. Then we can have the impulse conducted through to the ventricles. The ventricles contract. When they're nice and full, you get really good cardiac output that way. So when the impulse follows the normal conduction pathways, then the sequencing or the timing of the mechanical events that go along with that impulse, when the atria contract versus when the ventricles contract, the timing of those events is such that you get maximum cardiac output, maximum ventricular filling, maximum stroke volume, maximum cardiac output. Now, if for some reason the SA node is not functioning as the pacemaker, and if the AV node has to take over as the pacemaker, you're going to see a much slower rate. Generally, you're going to see something around 40 to 60 beats per minute. The Purkinje system is the part that we said controls ventricular activity, and the Purkinje system starts where the AV node ends with the bundle of His, or sometimes people call it the AV bundle. And then from the AV bundle, then we have the right and left bundle branches as the conduction system travels down the septum in between the two ventricles. And then as the fibers fan out over the outer walls of the ventricles, then they subdivide into smaller and smaller fibers. We call those the Purkinje fibers. And once the impulse hits the Purkinje system, the impulse travels very, very quickly through the Purkinje system so that pretty much all of the ventricular walls are depolarizing at the same time, contracting at the same time, so we get a nice, strong force of contraction, we get good stroke volume, we get maximum cardiac output. Now, if the Purkinje fibers have to serve as the pacemaker, then we're going to see even slower rate of slower heart rate. We'll get somewhere between 15 to 40 beats per minute. Now, to understand how the pacemaker cells generate their own action potentials, we probably need to review a little bit about the physiology of action potentials from way back in the first week of class. You remember that action potentials are little electrical currents that pass through nerve and muscle cells and act as a trigger for certain cell activities. Now, in the case of the heart muscle, when you get that action potential, that triggers the heart muscle to contract. Now, you remember that the resting heart muscle cell is electrically polarized, right? Meaning that the inside of the cell is more negatively charged than the outside. In order to generate an action potential, the permeability of that cell membrane has to change, allowing the positively charged sodium to enter the cell, and the inside of the cell is going to change from negative to positive. That's what we call depolarization. That's what triggers the contraction of that heart muscle cell. Usually, action potentials in muscle cells are triggered by the nervous system. The nervous system is the thing that provides the stimulus that allows the positively charged sodium to enter the cell and depolarize it. However, in the heart conduction system, especially in the SA node and the AV node, the cell membrane permeability is a little different than in normal muscle cells, like your skeletal muscle cells. In the SA node and the AV node, the membrane permeability is such so that there's always a slow inward leak of sodium into the cell. Now, you remember in your nerve cells and in your skeletal muscle cells, the cell membrane really is not permeable to sodium. But in your SA node and your AV node, there is always a slow inward leak of sodium into the cell. And when enough sodium gets into the cell will spontaneously depolarize without any need for the nervous system to come along and trigger the entry of sodium. So that's how the heart muscle cells can generate their own action potentials, because they don't need the nervous system to provide the trigger to allow the sodium to enter the cell. The cell membrane in the SA node and the AV node is such so that sodium is always sort of slowly leaking into the cell. And when enough sodium gets into the cell will spontaneously depolarize. Now, when I say that there's a slow inward leak, slow is, of course, a relative term, right? Because this happens every single time the heart beats. Okay, so it really isn't all that slow, but in terms of cellular life, I suppose it's a slow process. But this is how the heart muscle cells can generate their own action potential. They do not need the nervous system to come along and provide that stimulus. We call that capability automaticity. Automaticity is what gives the SA node and the AV node their pacemaker capability, because they can spontaneously depolarize. They don't need any input from the nervous system in order to do that. Another related idea that we need to talk about before we can talk about dysrhythmias is the idea of a refractory period that follows an action potential in a heart muscle cell. Now, there are actually two phases to the refractory period. There's an absolute refractory period and there's a relative refractory period. During the absolute refractory period, you cannot generate another action potential. Okay, so this is a time after an action potential has occurred where you cannot generate another action potential. No matter how big a stimulus you use, you cannot generate another action potential. Now, the absolute refractory period is longer in heart muscle cells than they are in skeletal muscle cells. Why do you think the refractory period or the absolute refractory period has to be longer in the heart muscle cell? The absolute refractory period has to be longer in the heart muscle cell to prevent a second muscle contraction from occurring before the first one is over. Okay, now if we're talking about your bicep muscle, like a skeletal muscle, okay, if a second contraction occurs before the first one has ended, it really doesn't matter that much. Your bicep will just stay contracted and maybe your muscle will get tired, but nothing worse than that is probably going to happen. But if your heart muscle cells were to contract and then a second contraction were to occur before the first one was over, what would happen in your heart? Okay, if a second contraction occurs before the first one ends, then you basically go into cardiac arrest, right? In your heart, you have to have that contract, relax cycle. Otherwise, if your heart just contracts and it stays contracted, you lose the pumping action of the heart. The heart will never fill, and so cardiac output is going to drop. Okay, so you have to have the absolute refractory period being a little bit longer in the heart muscle cells to make sure that a second contraction does not occur before the first one ends, to make sure that you don't go into cardiac arrest. After the absolute refractory period, then we have what we call the relative refractory period. And during the relative refractory period, you can generate another action potential, but only if you have a stimulus that's much bigger than normal. So during the absolute refractory period, you cannot generate another action potential no matter how big the stimulus is. During the relative refractory period, you can generate another action potential, but only if you have a really, really big stimulus. After both of the refractory periods are over, then we have what we call a supernormal excitatory period. And during the supernormal excitatory period, even a very weak stimulus can generate another action potential. And the reason why I want you to pay attention to the relative refractory period and the supernormal excitatory period is because if you have a change or an abnormality in those two periods, that can predispose you to a cardiac dysrhythmia. Okay, I think now we have a good enough understanding of the cardiac action potential to cover some basic concepts about EKGs. EKG is an electrocardiogram. Actually, a lot of people call it an ECG because if you think about it, there really isn't a K in the word electrocardiogram. But anyway, here you see a patient having an EKG done. This is the one where we hook electrodes up to the patient's chest and we get a recording of the electrical activity of the heart. And what we're looking for are changes in the patterns of the electrical activity, because if you see those changes, that usually indicates that there's some kind of cardiac conduction problem or some kind of dysrhythmia. Well, let's talk a little bit about the basic elements of the EKG, and then we'll talk about what they represent. Okay, now you know the EKG is recorded on graph paper like this, and as you go horizontally from side to side, okay, that measures time, that represents time. And if you go vertically or you go up and down, that represents the amplitude or the magnitude of the electrical impulse. And in a normal EKG tracing, you're going to see a P wave, a QRS complex, and a T wave. A P wave, QRS complex, and a T wave. Now the P wave represents depolarization of the SA node and the atria. The QRS complex represents depolarization of the ventricles. And the T wave represents repolarization of the ventricles. So we have depolarization of the atria, depolarization of the ventricles, and repolarization of the ventricles. What event seems like it's missing there? What happened to repolarization of the atria? Well, actually, repolarization of the atria occurs at the same time as depolarization of the ventricles. And the depolarization of the ventricles generates a much bigger magnitude impulse. And so the repolarization of the atria, while it's happening, is hidden in the QRS complex. So it looks like it's missing in the EKG. It's really not. It's just that you can't see it because it's covered up by the QRS complex. In order to be considered normal, or what we call normal sinus rhythm, there are a few things that you have to see in the EKG. First of all, there has to be a P wave in front of every QRS. Okay, so if you look at this strip, you see that there is a P wave in front of every QRS complex. And the second thing you have to see is the R to R intervals have to be constant, or they have to be equally spaced apart. Okay, R to R interval means the space between the R's. And you remember that tenthly peak thing, that's a QRS complex. And the R is the top of that complex. So the distance between the tops of those QRSs, that's the R to R interval. And in order to be considered normal sinus rhythm, the R's have to be evenly spaced apart, because that indicates that the rhythm is regular, right? If you have some R's that are closer together and some that are farther apart, then that indicates that this person has an irregular heart rhythm. Some beats are closer together, some beats are farther apart. In order to be considered normal sinus rhythm, there has to be a P wave in front of every QRS, and the R to R intervals have to be even. All right, let's talk about dysrhythmias. Actually, before we get into the dysrhythmia, let me clarify the term. When you read your book or you look at a lot of journal articles, they're going to talk about arrhythmias instead of dysrhythmias. Now, when I went to nursing school, we talked about them as arrhythmias. But somewhere along the line, several years ago, somebody said, arrhythmia is really not an accurate term, because when you put the prefix A in front of something, what does that usually mean? It means without, right? And when somebody has a dysrhythmia, it doesn't mean that they are without a cardiac rhythm. It just means that it's a bad rhythm or an abnormal rhythm. So they said, let's start saying dysrhythmia instead of arrhythmia, because the prefix dys means bad, or it indicates that there's a problem, so that it's a much more accurate term. But in the last couple editions of your textbook, they said, the term dysrhythmia never really caught on, so we're going to go back to calling them arrhythmias. Well, by the time that happened, I'd already gotten used to calling them dysrhythmias, and I really like that term better because I think it's more accurate. So I still call them dysrhythmias, but I just want you to know that when you go to the hospital and you look in charts, you might see some people using the term dysrhythmia, other people using the term arrhythmia. It means the same thing. Okay. So, cardiac dysrhythmia is a change in the cardiac rhythm that can potentially interfere with the pumping action of the heart. Okay, that's the reason why we care whether the patient has a cardiac dysrhythmia, because when you change the rhythm of the heart, you might potentially interfere with the pumping ability of the heart and mess up cardiac output. Okay, remember we said when a cardiac impulse follows the normal conduction pathways, then the sequencing of when the atria contract versus when the ventricles contract is timed to give you maximum cardiac output. It's timed so that the atria can completely empty into the ventricles can be nice and full before they contract, so you can have maximum cardiac output. If you interfere with the normal conduction pathway, then you might mess up the timing of when the atria versus the ventricles contract, and that can interfere with cardiac output. So the main reason why we care whether people have dysrhythmias is that it can drop their cardiac output. Cardiac dysrhythmias are usually caused by one of three kinds of things: either problems with automaticity, problems with conductivity, or problems with what we call re-entry mechanisms. Let's just say a few words about each of those problems. Starting with problems with automaticity. Do you remember what automaticity is? Okay, remember we said automaticity was the ability of the heart muscle cells to generate their own action potentials without any need for input from the nervous system. Okay, when you have a problem with automaticity, it's usually going to result in one of two different kinds of things. Either a change in heart rate or a premature ectopic beat. Now, obviously, if you have the heart muscle cells generating a rate that's too fast or a rate that's too slow, it can cause problems with cardiac output, right? If your rate is too slow, cardiac output's going to drop. If your rate is too fast, the heart doesn't have time to fill in between each beat, so again, cardiac output drops. What about premature ectopic beats? What's an ectopic beat? Do you know what the word ectopic means? Okay, it usually means from an abnormal location, right? Like, for example, what is an ectopic pregnancy? An ectopic pregnancy is a pregnancy that occurs outside of the normal location. Pregnancies are supposed to occur in the uterus, but an ectopic pregnancy, you sometimes see the embryo implanting in the fallopian tube or something like that. But it's in an abnormal location. So an ectopic beat is a beat that's generated from an abnormal location. Cardiac impulses are supposed to be generated from the SA node. But if some heart muscle cells somewhere else in the heart decides that it wants to be the pacemaker, it might generate its own action potential, and then we would call that an ectopic beat. So you see in this slide, the green dot is an area of heart muscle cells that have decided to generate their own action potential, and so they're creating an ectopic beat. Now that can happen because, remember automaticity? We said that pretty much all heart muscle cells can generate their own action potentials. So sometimes a heart muscle cell somewhere other than in the SA node decides it wants to generate an impulse, and so it becomes an ectopic pacemaker. Now, the way that ectopic cells can take over from the pacemaker, from the true pacemaker, the SA node, is to come out with their ectopic impulse before the SA node comes out with its impulse. So in other words, the ectopic beat has to be premature. That's how it steals the role from the SA node, by coming out with its ectopic impulse before the SA node comes out with its normal impulse. So you see in this particular EKG strip, we have what we call a premature ventricular contraction. The red arrow is pointing at the premature contraction, and you see that the premature contraction did come early. It's not quite in the middle of the two black arrows. And a normal beat would be exactly in the middle of those two arrows. So that is a premature beat, and you can also tell that it's an ectopic beat because it did not follow the normal conduction pathway, and that's why it's so much wider than it's supposed to be. Because remember, if an impulse follows the normal conduction pathway, it travels much more quickly. An ectopic impulse doesn't follow the normal conduction pathway, so it's going to take a lot longer, and the complex is going to be what your book refers to as wide and bizarre looking, because it just took so much longer because it didn't follow the normal conduction pathway. So we have these premature ectopic beats. They're generated from someplace other than the SA node. They're premature because that's the only way it can steal the pacemaker role from the SA node. And once an ectopic pacemaker has stolen the pacemaker role from the SA node, it often becomes very difficult for the SA node to take back over, because what happens is when the cells around the ectopic pacemaker follow the ectopic pacemaker, then by the time the SA node comes out with its next impulse, all the cells have depolarized. They're in the refractory period. Nobody can depolarize again. so they can't follow the SA node. By the time the cells have repolarized, then the ectopic pacemakers come out with another ectopic impulse, and all the cells follow that again. So you see, once an ectopic pacemaker has established itself, it can sometimes be very difficult for the SA node to take back over and become the normal pacemaker. Now, what do you suppose is so bad about having an ectopic pacemaker? I mean, the heart's still beating, right? So why does it matter whether the impulse is generated from the SA node or from somewhere else? Well, remember we said that when the impulse follows the normal conduction pathway, the sequencing of when the atria contract versus when the ventricles contract is timed to give us maximum cardiac output, okay? Look at the ectopic pacemaker in this particular slide. If that ectopic pacemaker generates an impulse and all the cells around it start to depolarize, look at the green arrows. That's the direction that the wave of depolarization is going to follow. So if we're following that ectopic pathway, which heart chambers are going to depolarize first, the atria or the ventricles? It looks to me like the ventricles are going to depolarize first, which means the ventricles are going to contract before the atria do. And if the ventricles contract before the atria do, what's going to happen to ventricular filling? It's going to drop. And if ventricular filling doesn't occur, what's going to happen to cardiac output? Cardiac output's going to suffer. So you see why we really worry about these dysrhythmias, because they can seriously impair cardiac output. Okay, the second kind of thing that can lead to dysrhythmias, problems with conductivity. When you have problems with conductivity, it's usually going to cause either a conduction delay or a complete conduction block. And these kinds of problems are usually caused by scar tissue from an old heart attack, or maybe an electrolyte imbalance, or the presence of inflammation in the heart wall. Those kinds of things all interfere with normal conduction. Now, you see the heart pictured under B in this slide. Has a little area where there's some scar tissue or something, and it's causing a blockage of the conduction of that electrical impulse through the left bundle branch. And so it's causing what we call a left bundle branch block. The problem with those kinds of blocks and delays is that it causes the different parts of the ventricle wall to depolarize at different times. So instead of all of the ventricular walls contracting at the same time, you're going to have some parts of the wall contracting at earlier times than others, and so you're not going to get that nice, strong force of contraction. You're not going to get a good stroke volume. You're not going to get good cardiac output. Now, the other thing that happens when you have conduction problems, it can predispose you to re-entry mechanisms. And re-entry mechanisms happens to be the third kind of thing that can predispose you to dysrhythmias. So let's talk about re-entry mechanisms. A re-entry mechanism is what you have when you have a cardiac impulse that re-enters an area of the heart wall that is already depolarized and depolarizes it again. Okay, so you end up with areas of the heart wall that are depolarized 2 or more times by the same cardiac impulse. Okay, so you have an impulse that's re-entering an area that's already depolarized, depolarizing it again, so that you have heart tissue that is being depolarized 2 or more times by the same cardiac impulse. Now, what's supposed to happen is what you see in that picture on the left where the black arrow is pointing at. Okay, this is sort of a depiction of a cardiac impulse that's coming down the normal conduction pathway. And, the impulse and the wave of depolarization kind of spreads out in all directions. And what happens is that impulse eventually is going to die out because it spreads out in all directions. It depolarizes all the cells around it. all the cells go into their refractory period. They cannot depolarize again. And so that first impulse dies out. And by the time all the cells repolarize, well, the SA node has generated another impulse. And so all the cells are depolarized by that second impulse. So under normal conditions, all heart muscle cells are only depolarized by one particular impulse once. And then that impulse dies out. When there's a conduction delay or a conduction block, as you see in that last drawing where the black arrow is pointing, now you might see a different picture. What you see in that diagram is the impulse coming down through the normal conduction pathways, trying to spread in all directions, but you see that there's an area of scar tissue or something, and so conduction in that area is blocked. Well, the impulse travels in all of the unblocked areas until it circles around and comes back to that area where the impulse was blocked. In this particular direction, however, instead of the impulse being blocked, it's only delayed. So the impulse does eventually make it through that area of tissue, but it gets there a lot more slowly than it normally would because it was delayed as it got through that scar tissue. Once that impulse makes it through the scar tissue, all the tissue in that area, or all the heart muscle cells in the area that is now re-entering, have had time to repolarize. And so that impulse can re-enter the area and depolarize it again. It's depolarizing an area more than once. It's re-entering an area that's already depolarized and depolarizing it again. What you see in this particular picture is another way to look at the re-entry mechanism. So you see there is an area of delay in the septum between the two ventricles, and by the time the impulse makes it through the outer ventricular wall, it's re-entering an area that has already been depolarized, and it's depolarizing it again. And so what you see with these re-entry mechanisms is an impulse circling around, depolarizing an area over and over again. Now again, you might wonder, why is this a problem? Because the heart is still beating, right? The heart muscle cells are still contracting. Why is this a big problem? Again, remember, the problem is that we said that the sequencing of when the atria contract versus when the ventricles contract is ideal when you follow the normal conduction pathways. If you have a re-entry mechanism, then we're no longer following the normal conduction pathways. We're potentially interfering with when the atria contract versus when the ventricles contract. We are potentially interfering with ventricular filling, which can interfere with good cardiac output. So again, the big problem with all of these cardiac dysrhythmias, we're worried that cardiac output is going to be impaired. And just one last picture to illustrate how the impulse involved in a re-entry mechanism can keep circling around and around and around and depolarizing the same area more than one time. So we've said that dysrhythmias are usually caused by problems with automaticity, conductivity, and re-entry mechanisms. But what we haven't said yet is, what is it that causes those problems with automaticity, conductivity, and re-entry mechanisms? So I actually have those predisposing factors listed for you on your study guide, but let's just quickly review them. Maybe somebody is born with a defect of their conduction system. It might be a congenital thing. Or they might have been born with a normal conduction system, but that conduction system got injured or damaged at some later point. Maybe they had a disorder like a cardiomyopathy that caused degenerative changes in the conduction system. Maybe they had an event like a heart attack that, caused scar tissue to form in
the walls of the ventricles, and that scar tissue can't conduct electrical impulses, so now we have conduction blocks and delays. Maybe they have some kind of disorder that's causing inflammation in their heart, and the inflammation can possibly change the length of refractory periods, conductivity, and those kind of things. Electrolyte imbalances are also big. You already know from our discussion on how action potentials are generated that sodium and potassium play a big role in that, especially the concentration gradients of the sodium and potassium. So you can imagine that electrolyte imbalances may interfere with the action potential generation and lead to some cardiac dysrhythmias, or at least, interfere with the supernormal excitatory period or the length of the refractory period, those kinds of things. Some of the medications that we give people, whether they're prescription or over-the-counter, and some other kinds of drugs that patients take, whether they're herbals or whether they're, recreational drugs, some of those can also potentially change refractory periods or conductivity. So those are all the kinds of things that can lead to automaticity, conductivity, re-entry problems. Some of these things we mentioned can come on quickly. Some of them occur more gradually over time. Some of these we can change. Some of these we cannot fix. But these are the kinds of things that we're going to look for if we have a patient having dysrhythmias and we're looking for why that is. As far as assessment findings, that's really going to depend on which specific dysrhythmia the patient has. But there are a few things that are true in general. For example, if the dysrhythmia is generating a rate that's too slow, what do you think is going to happen to cardiac output? It's going to drop, right? On the other hand, if the dysrhythmia is generating a rate that's too fast, now what do you think is going to happen to cardiac output? It's still going to drop, right? Because if the heart rate gets too fast, then the heart doesn't have time to fill in between each beat, and the cardiac output is going to drop. Not to mention that when the heart rate gets really fast, what happens to the workload of the heart? The heart has to work harder, meaning now it's going to need more oxygen so it can make more ATP. And if this patient has atherosclerosis in their cardiac, their coronary arteries, they might not be able to provide the heart muscle with that much extra oxygen. So we might actually be setting this person up for a heart attack. So notice that we said that with rates that are too slow and too fast, the big thing we worry about is a drop in cardiac output. So the next question then becomes, well, what are the symptoms of decreased cardiac output? Because those are the things that we should be monitoring our dysrhythmia patients for, right? Well, the symptoms of decreased cardiac output are going to depend on how severe the decrease is, right? So if it's just a mild decrease, we'll probably see the patients just complaining of things like being tired and having poor activity tolerance. But if the drop in cardiac output is more severe, now we're going to see people complaining of maybe dizziness, fainting, and some hypotension. What if the drop in cardiac output is really bad? Then we'll be looking at people in heart failure or maybe even shock. So I want to show you a few of the more common cardiac dysrhythmias. I'm not going to show you all of them because there's a whole bunch of them, but I do want to show you a few that you are more likely to run into in the clinical setting. Now, I'm not going to test you on the specific dysrhythmias. In other words, I'm not going to show you rhythm strips and ask you to identify which dysrhythmia is this. Okay, you probably won't do that until critical care. But even though you're not really going to study about dysrhythmias in detail until then, when you work with patients in the clinical setting, you will be working with patients who are on telemetry, who are having EKGs done, and I do want you to have at least some idea of what it is that you're looking at. Okay, so I'm going to show you these different dysrhythmias. Again, I'm not going to ask you questions about specific dysrhythmias. On the test, I will probably be asking you more stuff like, what are the basic elements of the EKG? What are the predisposing factors to dysrhythmia? Why do we care whether people have dysrhythmias? And then what are the interventions? Okay, so the stuff that we've been talking about up till now, that's the stuff that I'll test you on. And these specific dysrhythmias that we're going to look at now, I'm not going to ask you any questions about the actual dysrhythmias themselves. All right? Okay, so what you see on the top of this picture is normal sinus rhythm. Okay, so that's what your EKG is supposed to look like. Sinus bradycardia and sinus tachycardia are examples of sinus node dysrhythmias. And, since you know that your SA node is the pacemaker of the heart, it probably shouldn't be too surprising that the kinds of dysrhythmias that it causes are usually problems with heart rate. So sinus bradycardia, brady means slow, tachy means fast. So as you might expect, sinus bradycardia would be if your heart rate drops below 60, sinus tachycardia if your heart rate gets over 100. But there are really no other abnormalities in the EKG pattern here. Now, you can kind of just look at this EKG and tell, right? Because you'll notice how few complexes there are on the sinus bradycardia strip and how many more there are on the sinus tachycardia. So you can just kind of look at how close the complexes are together, and you can already sort of tell if this is a fast rhythm or a slow rhythm, right? Sinus tachycardia and sinus bradycardia actually in some circumstances can be normal. Like if I took you all down to the Drayson Center and made you start running around the track, I would expect you all to go into sinus tachycardia, and that would be perfectly normal, right? If I took you to the Drayson Center and made you run around the track a bunch of times every day for like 3 years, okay, you might become so fit that your resting heart rate might drop below 60. You've probably heard of some of these Olympic athletes whose resting heart rate is like 45 or something because their heart muscle is so strong, they have such great stroke volume that they can generate a good cardiac output even with a slower than normal heart rate. So those are two examples when sinus dysrhythmias are actually normal and not pathological. But I don't want to give you the idea that all sinus node dysrhythmias are harmless, because there are some that can kill you. So the dysrhythmia you see in this picture is an atrial dysrhythmia. It's not an SA node dysrhythmia, but it still originates in the atria. It's called atrial fibrillation or AFib. And what happens in AFib is that the impulse, instead of getting conducted through the atria in a nice orderly manner, it's what we call, quote, grossly disorganized. Okay, so you see that the impulse is being conducted through the atria in a very random manner. It's kind of bouncing all over the place, and so those impulses, since they're not following the normal conduction pathway, they're only really randomly getting conducted through the AV node into the ventricles. And because of that randomness, it's generating a very irregular rate and rhythm. Okay, so these are the people, if you try to feel their pulse, their radial pulse, it's very irregular, and you would have to count this person's pulse for a full minute in order to get an accurate reading, because, if you were to just count their heart rate for 15 seconds and multiply by 4, or for 10 seconds and multiply by 6, depending on which 10 or 15 second interval you counted for, you might get very different values. Okay, so here is somebody who's going to have a very irregular heart rate. Now, because the impulses are not following the normal conduction pathway through the atria, what we're going to see is different parts of the atrial wall trying to contract at different times. So instead of having a nice unified atrial contraction, we're going to see the atrial walls just sort of quivering because different parts of the wall are trying to contract at different times. So if you had this person's chest cut open and you're actually looking directly at their heart, that's what you would see. Now that creates two problems, right? First of all, if you don't have a nice coordinated atrial contraction, you're not going to fill your ventricles very well, right? And so what might happen to cardiac output? It's going to drop, right? But the other thing that we worry about is since the atria are not contracting in a coordinated way, the blood is just sort of pooling or collecting in the atria. It may eventually drain into the ventricles, but, it's not moving through in the way it's supposed to. It's just sort of collecting in the atria. And whenever you have blood that's just collecting, it's just pooling, what does it want to do? It wants to clot, right? So people with atrial fibrillation are at high risk for forming a lot of clots in their atria, which could then drain into the ventricles and eventually get pumped out to different places in the body. And if those clots get pumped out and get stuck in an artery somewhere, it can cause a lot of problems. In fact, atrial fibrillation is one of the most common causes of ischemic strokes, to the point where if somebody goes into the emergency department and they have symptoms of a stroke, one of the first things we're going to do is we're going to hook them up to an EKG and see if they're in AFib, because that is such a common cause of stroke. Ooh, by the way, I almost forgot to mention, you can tell that the activity in the atria is very disorganized. When you look at that EKG, do you see how you don't see a distinct P wave, right? You just see a whole bunch of scribbly stuff, okay? So that indicates that what's going on in the atria is very disorganized. What you're looking at here are some dysrhythmias of the AV node. And you remember that the AV node is the connection between the atrial conduction system and the ventricular conduction system. So if there's a problem with the AV node, as you might expect, we have problems conducting impulses from the atria into the ventricles. Usually we call it AV block, or sometimes we call it heart block. And you'll notice that there are 3 degrees of AV block, depending on how severe the block is. We have 1st degree, 2nd degree, and 3rd degree AV block. Okay, so in 1st degree AV block, what you have is conduction being delayed through the AV node, but every impulse is eventually making it from the atria to the ventricles. And you can tell that because every P wave does have a QRS complex following it. The way you know that conduction through the AV node was delayed is if you look at the space between the P wave and the QRS and you compare it to the normal. Okay, do you see how the space between the P wave and the QRS is a little longer in 1st degree AV block than it is in the normal sinus rhythm? Okay, so that little extra space tells you it took longer for that impulse to conduct from the atria through the AV node into the ventricles, and so you know that there was some delay. But the block is not that severe because, again, every impulse did make it through the AV node, so every P wave is followed by a QRS. In 2nd degree AV block, the blockage in the AV node is worse. And the way you know that is because you can see that not every impulse is actually making it through from the atria to the ventricles anymore, right? Because you can see some of those P waves don't have QRS complexes after them anymore. That tells you that there are some impulses that are not making it through the AV node at all. So you know the blockage is more severe. By the way, there are actually two different kinds of second-degree AV block, which I'm not going to bother you with right now, but when you get into critical care, you are going to need to know the difference. So here's like a little poem that may be able to help you remember the differences. So when you get to critical care, you can refer back to that poem. In third-degree AV block, the block of conduction through the AV node is complete. Okay, so no impulses are actually making it from the atria into the ventricles. Because no impulses are coming from the atria, what happens is that an ectopic pacemaker is going to arise in the ventricles, and so the atria are going to be doing their own thing, and the ventricles are going to be doing their own thing, but they have no relationship to each other. They're totally independent of each other. Now you can tell that the atria and the ventricles are doing their own separate thing because if you look at the EKG, you'll see that the P waves are evenly spaced apart. And if this strip were long enough, you could see that the QRS complexes are evenly spaced apart. And so they're doing their own thing, but the P waves and the QRS complexes have no relationship to each other at all. They're totally independent of each other. So that's what happens when the block through the AV node is complete. Next, we're going to look at some ventricular dysrhythmias, which do tend to be a little bit more serious than atrial dysrhythmias, because you remember your ventricles are your main pumping chambers of your heart, right? So if you mess with the ventricles, there is more potential for interfering with good cardiac output. The first ventricular dysrhythmia I want to look at is the PVC, otherwise known as premature ventricular contractions. And we've already sort of talked about the premature ectopic beats, right? We know that they're caused by an ectopic pacemaker. So someplace in the ventricles decides it wants to be the pacemaker and generates an impulse that the other ventricular heart muscle cells follow. We know that it's not following the normal conduction pathways because it's producing that wide, bizarre-looking complex. We know it's premature. That's how it steals the pacemaker role from the SA node, right? And you can tell that this PVC happened early because if you look at the two normal contractions, the PVC is not exactly in between those, right? If it were a normal contraction, it should be exactly in between the two normal ones. And this one obviously came early. So we have a premature beat that came from an ectopic pacemaker. The reason we care about it is because it happened early. We're not following the normal conduction pathway, so when we sequence the atrial contraction versus the ventricular contraction, it could interfere with cardiac output. So this is probably a good time to introduce this term, atrial kick. Just in case you hear it in the clinical setting, you'll know what they're talking about. Atrial kick just refers to when the atria have a chance to have a nice strong contraction and fully empty into the ventricles and give us maximal cardiac output. We call that atrial kick. And the reason why we worry about a lot of these cardiac dysrhythmias is because they interfere with the timing of when the atria contract versus the ventricles contract. Then we lose our atrial kick and we might not have good cardiac output. So when you have a premature beat, like a PVC, can you see how there is the potential for the atrial kick to be lost, right? Because since the PVC happens early, it probably happens at the same time that the atria are contracting, and so the ventricles aren't getting maximally full, okay? Now, sometimes people just throw one PVC here or there. This person actually has every other beat as a PVC, so that is getting a little bit more dangerous. But there are some people who think that everybody throws a PVC every now and then. And if you only have one every now and then and you don't have any other heart problems, it's probably not going to really matter. Okay, but if you have a lot of PVCs, then that can predispose you to some more serious dysrhythmias, and that's when we're actually going to start worrying. Here we have ventricular tachycardia, otherwise known as VTach, and if you look at that EKG, it kind of almost looks like a whole bunch of PVCs all strung together, right? The big problem with ventricular tachycardia is that it does generate a really, really fast rate. It can be anywhere between 100 to 250 beats per minute. And if you think about something like 240, 250 beats per minute, that's like, what, 4 beats per second? Okay, so if your heart is beating that fast, is there going to be time to fill in between each beat? No. Okay, and there's totally not going to be any atrial kick, right? There's no time for the atria to contract and fill the ventricles. So what do you suppose is going to happen to cardiac output? Yeah, it really drops. If we don't get this person out of this rhythm fairly quickly, we're in big trouble. And finally, this one is ventricular fibrillation, or VFib. So remember in AFib, we said that the impulses were being conducted in a very disorganized, random manner, and we had different parts of the atrial wall trying to contract at different times. Okay, we've got a similar thing going on, only in the ventricles this time. So you see the EKG tracing is just totally disorganized because there's nothing orderly about what's happening in VFib. We have impulses all, being conducted randomly throughout the ventricles. The different parts of the ventricular wall are trying to contract at different times. So now this time it's the ventricular walls that are just quivering instead of the atrial walls. And of course, if your ventricular walls are just quivering and are not contracting, what's going to happen to cardiac output? It's going to totally disappear, right? So unless you can get this patient out of this rhythm quickly, they're going to die. Again, you'll cover a lot more about dysrhythmias and EKGs when you get into critical care. I just want to finish up with just a brief discussion of interventions for dysrhythmias. Of course, the primary thing we want to do is try and figure out why the patient's having the dysrhythmias, and if we can get rid of the cause, we'll try and do that. So maybe it's because they have electrolyte imbalances. We try to correct the electrolyte imbalance, and hopefully the dysrhythmia should go away. Okay, sometimes the cause of the dysrhythmia is not something that you can get rid of. Or sometimes we can't figure out why they're having a dysrhythmia. In those situations, our two options are either to give antidysrhythmic drugs or electrical interventions. Okay, let's talk about the antidysrhythmic drugs first. Now, I don't want to go into too much detail on the antidysrhythmic drugs because there are a lot of them. And when you start looking at how each of them works, it does get kind of technical. So for now, all I want you to remember is that most of these antidysrhythmic drugs work by changing the permeability of the heart muscle cell membrane to different electrolytes. Okay, so we have the potassium channel blockers, the sodium channel blockers, the calcium channel blockers. They're all working by somehow changing the permeability of the cardiac muscle cell membrane to these different electrolytes. And when they do that, that changes automaticity, that affects conductivity, that changes the refractory periods, and therefore changes the generation of action potentials. Does that make sense? That's all I want you to know for now. The other kind of interventions that we might use are electrical interventions, like electronic pacemakers. We can use pacemakers to treat certain kinds of AV block or certain Brady dysrhythmias, in other words, dysrhythmias that are generating a slower than normal rate. Now, you'll notice that the pacemaker has a generator that serves as the body of the pacemaker, and then it's connected to some leads that are going to transmit the electrical impulses that the generator produces. Now you can see that those leads are positioned in the heart, in the atria and the ventricles to kind of lay against the heart wall, and the pacemaker actually can sense what rate the heart is generating, and we can set the pacemaker so that if the heart rate drops below a certain level, then the pacemaker will generate an electrical impulse that should stimulate the heart to contract, and in that way we can keep the heart rate in a more acceptable range. And you usually can see the pacemaker generator on the chest wall under the skin. There'll be like a little pacemaker-sized lump on the patient's chest. And so we have the pacemaker there to initiate heartbeats when the heart isn't generating a fast enough rate. The other kind of electrical intervention that we might use is called defibrillation. And what we're doing in defibrillation is we're using a much bigger electrical stimulus than we use with the pacemaker. What we're trying to do is to deliver a big enough electrical stimulus to hopefully depolarize all the heart muscle cells all at the same time. And what we hope to accomplish by that is to interrupt all the disorganized impulses that might be running around in the heart, and to kind of reset the heart so that the SA node can hopefully regain control. I'm sure you're all familiar with what defibrillation looks like, and as a matter of fact, I know you all had to take CPR, so you probably learned how to use the AED, right? So you've had some experience with it. When you worked with the AED, I'm sure you noticed that sometimes the AED will recommend a shock and sometimes it won't, right? So there are some rhythms that are, quote, shockable that we might be able to correct with defibrillation, and others that are non-shockable. In other words, other rhythms, defibrillation isn't going to help any. Okay, when you get to critical care, you'll learn a lot more detail about which rhythms are shockable and which ones aren't, and what we do if the rhythms are not shockable. Because sometimes we can try and give some medications that might change a non-shockable rhythm into a shockable one. Sometimes that won't even help either. All right, that's all I want to cover about dysrhythmias for now. Let's switch gears and talk about the respiratory system. All right, so our goal for respiratory for today is to get through a review of normal function of the system, and then we'll talk about some common respiratory disorders next time. So the main job of the respiratory system is to provide a means for gas exchange to support the metabolic activity of the body cells. Now, when we use the term gas exchange, we're referring to the process in which oxygen moves into the blood and carbon dioxide is removed from the blood so it can be exhaled from the body. Now, by that definition, what problems do you think are going to happen if respiratory function becomes impaired? If gas exchange is impaired, we're going to have hypoxia, not enough oxygen, and hypercapnia, too much carbon dioxide. Okay, and if you don't have enough oxygen, cells can't make ATP, they're going to malfunction and die, right? Let's briefly review a little bit about the structure of the respiratory system. Starting from the top, we have the conducting airways, which are just the passages that the air moves through as it goes back and forth between the atmosphere and the lungs. And the function of the conducting airways is to warm, moisten, and filter the air that you breathe. Gas exchange does not happen in the conducting airways. It just warms, moistens, and filters the air. Now, the conducting airways are made up of a few different layers. At the higher levels of the conducting airways, we have rings of cartilage that surround the airway. And the purpose of those rings of cartilage is to make sure that the airways don't collapse when you inhale. The next layers in are 2 layers of smooth muscle that crisscross as they wind around the airway in opposite directions, And the role of the smooth muscle is to control the diameter of the airways. The very inside layer of the conducting airways is the mucosa, and that's the layer that contains the cells that make mucus and the cilia. And you remember what the role of the mucus and the cilia is, right? The mucus is supposed to trap dust and foreign particles that you might have inhaled, and then the cilia sweep that mucus up towards your pharynx so you can either cough it up or swallow it or whatever you want to do with that. Anyway, that is a protective mechanism, right? It's part of how the conducting airways filter the air. Some people call it the mucociliary blanket or the mucociliary escalator. So just in case you hear those terms, you know what we're talking about. Now, what if something impairs the function of your mucociliary blanket? Like maybe you smoke, because smoking kind of paralyzes the little cilia, right? So if you smoke and you paralyze your cilia, what problem do you think might occur? Well, you might get an infection, right? Because maybe the pathogens that are trapped in the mucus don't get swept out, and so they start an infection. Or maybe inflammation in your airways occurs because there's some irritant that was trapped in the mucus that didn't get moved on out. What if your mucosa gets swollen? Like, what if you have an infection or you have some kind of allergy that causes the mucosa in your airway to get swollen? What problem are we looking at then? It might cause some narrowing of the airway, so it might kind of impair airflow, right? What if the smooth muscle layers of your conducting airways were to constrict down really small? Now what problem would you have? And we would call that bronchospasm. The airways get so constricted we can't move much air through. It'd almost be like an airway obstruction, right? So even though gas exchange doesn't happen in the conducting airways, there are still things that could cause respiratory problems. Now, the conducting airways branch into smaller and smaller branches as you move down deeper into the lungs. And at the very end of the smallest branches, now you have the alveoli. And the alveoli is where gas exchange actually takes place. So you remember that the alveoli are surrounded by little pulmonary capillaries. And the oxygen in the alveoli moves into the blood in the capillaries, and then the carbon dioxide in the capillaries moves into the alveoli so it can be exhaled. So that's gas exchange. The alveoli is where the gas exchange actually takes place. So this is what we call the respiratory tissues of the lungs, because that's where gas exchange takes place. So here's a different way to look at the alveoli and the pulmonary capillaries that surround it. And you can see exactly where the oxygen and the carbon dioxide have to cross, right? They cross at the interface between the alveoli and the pulmonary capillary. And we call that interface the alveolar capillary membrane. So in this picture, you can see that the alveoli are actually composed of two kinds of cells. We have type 1 and type 2 alveolar cells. The type 1 alveolar cells are the thin pink cells in this picture, and these are epithelial cells, and this is the cell across which gas exchange takes place. So you see the pulmonary capillary right next to it, so gas exchange takes place between the type 1 alveolar cells and the pulmonary capillary. The type 2 alveolar cells are the cells that make surfactant. Do you remember studying about surfactant in A&P? What was the job of surfactant? Surfactant is a substance that is designed to decrease surface tension in the alveoli. Okay, so now the next logical question is, what is surface tension? Surface tension is like a cohesive property or an attraction between the molecules on the surface of a liquid. Because these molecules are attracted to each other, they want to be as close together as possible. That makes the liquid assume the shape that has the smallest surface area possible. Now, maybe you're wondering what that has to do with your alveoli. Notice that there's a thin film of liquid that lines that alveolus, and the attraction between the molecules on the surface of that liquid make those molecules want to get as close together as possible. And as those molecules try to get close together, it kind of starts pulling the alveoli shut. It kind of makes the alveolus tend to collapse. Surfactant helps interrupt the surface tension between the molecules on the surface of the liquid. It interrupts that attraction so that the molecules don't need to be that close together anymore. And that prevents the inward pull on the alveoli and helps the alveoli stay expanded instead of collapsing. Now, if there's a problem with your type 2 alveolar cells and they don't make surfactant, then the alveoli might start to collapse, and when that happens, we call it atelectasis. Now, atelectasis is just a term that refers to collapsing of alveoli. It doesn't tell you how many have collapsed. It could be just a small group of alveoli, or it could be like maybe a whole lobe of your lung. Okay, but the point being that if your alveoli are collapsing, you're not going to have good gas exchange, right? So you need the surfactant to help prevent atelectasis. Now, we know that one of the things that helps stimulate the production of surfactant is when you take a deep breath. Like, there are some people who think that that's the reason why people yawn, because you need to produce surfactant. Okay, so I know when I'm teaching class and I look out there and I see you guys yawning, I know it's not because you're bored, right? It's because you are trying to stimulate surfactant so that your alveoli don't collapse, right? Anyway, atelectasis is another one of those complications of immobility that we as nurses are supposed to be preventing. Because if you think about it, if you have somebody who's lying on their back in bed, that's a harder position to take deep breaths in, right? And so they tend to breathe more shallow, and then they don't make the surfactant, and then they get atelectasis. And you can kind of tell when people are getting atelectasis, because if the alveoli are collapsed, then not as much air is moving in and out of it, right? So when you listen to their lungs, you're going to hear decreased breath sounds over the area of the collapse. So anyway, we have a lot of things that we do as nurses to try and get people to take deep breaths. We will teach you about turn, cough, and deep breathing exercises, probably in fundamentals, I think. And then we encourage people to use their incentive spirometers. Now, if you've spent any time visiting hospital patients, you might have seen a little device that looks like this. This is an incentive spirometer, and it's to encourage people to take deep breaths. Now, it looks kind of like you should blow into it, right? But that's actually not how you use it. People are supposed to actually inhale, right? So they put their mouth around that tube, and then they take as deep a breath as they can, and as they inhale, that little marker moves up and down, and it tells them exactly how much air they breathed in, and, their goal is to take as deep breaths as they can. And, we encourage people to use their incentive spirometer like 10 times every hour while they're awake to make sure they're producing surfactant. And we even have cute little ones that we use for children to make it more like a game. One last thing I want to point out about this picture is notice that there are some alveolar macrophages in the alveoli. And of course, the job of macrophages is to phagocytize foreign stuff. So if a pathogen happened to get past your mucociliary blanket and got in your alveolus, then the macrophage would be there to try and get rid of it. Now, let's say something happened to your macrophages in your alveolus. Maybe you smoke and you killed off your alveolar macrophages. What problem would you be looking at? Probably infections and inflammations, right? From foreign stuff that didn't get, cleaned up. Okay, so we had the three kinds of cells here. The type 1 alveolar cells, this is where the gas exchange occurs. If something goes wrong with your type 1 alveolar cells, you're going to have a problem with gas exchange. There was the type 2 alveolar cells that make surfactant. If something goes wrong with your type 2 alveolar cells, you might see atelectasis. And then the alveolar macrophages, if something goes wrong with them, you probably get infections and those kinds of things. Let's talk about the pleura next. The pleura is a thin double-layered membrane that covers the outside of the lungs and lines the inside of the thoracic cavity. And it's one of those double-layered membranes that we said you always have to have whenever there's an internal organ that moves. Do your lungs move? Yes, they inflate and they deflate, right? And so you have to have one of those double-layered membranes with a small amount of serous fluid in between the layers so that as the lungs move, the tissues don't scrape each other raw as they rub against each other. So we have the pleural space in between the two layers of the membrane with that serous fluid in between. But, we think of the pleural space as a, quote, potential space, meaning that there is the potential for a space to be there, but there really isn't a space there because there's nothing in it. Okay, maybe it's not quite accurate to say there's nothing in it because there is that small amount of serous fluid that's in there that's designed to decrease the friction, right? But other than that, there's nothing in there. So those two layers of that double-layered membrane are basically resting right against each other because there's nothing in there. What we usually say about that potential space is there's a vacuum in there. It's negative pressure. It's a vacuum, so there's no air in there. So there could be a space in there if there was air in it, but there's no air in it, so it's just a vacuum. And that vacuum is what helps keep your lungs expanded. Because if you remember from A&P lab, hopefully you had a chance to look at some lung tissue. You remember that lung tissue is very elastic, right? It stretches like elastic stretches, but it also recoils like elastic does. So when you inhale and you inflate your lungs, that's like stretching out a piece of elastic, and it wants to recoil, it wants to collapse. And that vacuum in the pleural space, or that negative pressure in the pleural space, is what helps keep your lungs expanded. It keeps your lungs from recoiling and just collapsing. Now, this is what could happen if air gets in that pleural space and you lose that negative pressure or you lose that vacuum. Now there's nothing to help keep that lung expanded, so it's going to recoil and collapse. And when you get into, I think it's adult health 3 or critical care is when you're going to learn about how we insert chest tubes to kind of suck all that air out and so that the lung can re-expand. Another problem that can affect the pleura is the pleura could become inflamed. And what do you suppose we call that? Pleuritis, right? Or, if you've read history books or whatever, sometimes they talk about pleurisy. Pleurisy is the old-fashioned term for pleuritis. Pleuritis can occur in different kinds of lung infections. If the infection or the inflammation spreads to the pleura, then we have a pleuritis. And one of the primary symptoms of pleuritis is pain, or what we call pleuritic chest pain. Now, pleuritic chest pain is different from cardiac chest pain because you remember we said that cardiac chest pain was more like chest tightness or like an elephant sitting on my chest or something like that. Whereas Pleuritic chest pain is more of a sharp, stabbing type of chest pain that is aggravated by respiratory movement. And by respiratory movement, we mean when somebody coughs or takes a deep breath. Okay, so if somebody complains of sharp, stabbing chest pain when they cough or take a deep breath, that's probably not cardiac chest pain. That's probably more of a pleuritis. So that's one way we can differentiate between cardiac and respiratory-related chest pain. Oftentimes, pleuritic chest pain is on one side only because, if somebody gets an infection in their lungs, it doesn't automatically affect both lungs, right? So a lot of times pleuritic chest pain is unilateral. It is different from that kind of musculoskeletal pain that sometimes people get when they've been coughing for a long time. Sometimes the chest muscles get sore when somebody coughs really forcefully for several days. But that would probably be more bilateral. It would affect both sides. And it's not like a sharp stabbing kind of pain. Does that make sense? So can you sort of tell the difference between the two? All right. Now that we've looked at the structure of the respiratory system, let's take a look at the actual mechanics of breathing. How do we get the air in and out of our lungs? Well, basically, the movement of air in and out of the lungs is determined by three things: respiratory pressures, lung compliance, and airway resistance. So let's say a few words about each of those things. Respiratory pressures. Okay, movement of air in and out of the lungs is affected by changes in the air pressure gradient that results when the size of the chest cavity changes as you inhale and exhale. Basically, it works like this. When you inhale, the size of your chest cavity gets bigger. And when your chest cavity gets bigger, the air pressure inside your chest cavity drops below atmospheric pressure. So the air is going to flow into the lungs. When you exhale, the size of your chest cavity gets smaller. Now the pressure inside the chest cavity is greater than atmospheric pressure. So now the air is going to move out into the atmosphere. Does that make sense? So then the question becomes, well, what is it that causes your chest cavity to get bigger when you inhale and smaller when you exhale? The answer to that question is your respiratory muscles. When you contract your respiratory muscles, which are like your diaphragm, your external intercostals, when you contract those respiratory muscles, that makes your chest cavity get bigger. Right? It gets bigger from top to bottom, it gets bigger from side to side, it gets bigger from front to back. And that's what causes the air pressure inside the chest cavity to drop below atmospheric pressure and the air moves in. Exhalation is mostly passive. When you relax those respiratory muscles, then the chest cavity goes back to its original size. And now that the chest cavity is smaller, the air pressure inside is greater than atmospheric pressure, so the air is going to move back out of the lungs. So what do you think is going to happen if something goes wrong with your respiratory muscles? Like, let's say you fall off a horse and you get a spinal cord injury and now you can't contract your respiratory muscles anymore. What do you think is going to happen? Yeah, if your respiratory muscles don't contract anymore, the size of your chest cavity doesn't change, and air is not going to move in and out anymore. Okay, so your respiratory muscles are very important. So basically, in terms of respiratory pressures, it's the contraction of the respiratory muscles that changes the size of your chest cavity, and that is what changes your respiratory pressures and affects the ability of the air to move in and out of your lungs. All right, the second factor, lung compliance. And when we talk about lung compliance, we're just referring to how hard or how easy it is to inflate your lungs. It has to do with how elastic your lungs are. If your lungs are compliant, that means you can easily expand them. It's easy to move air in. If your lungs are non-compliant, that means you have to work harder to inflate your lungs. It's going to take more pressure to move the same amount of air into your lungs. So here's a little analogy that might help you understand compliance a little better. Have you ever tried to inflate a brand new balloon? You know, when the balloon has never been inflated before, it's really hard to blow up, right? You have to use so much force, you almost feel like your eardrums are going to blow out, right? And so let's say you inflate the balloon all the way, and then it slips out of your hand and all the air escapes, and now you have to blow it up again, right? The second time you blow it up, you don't have to work quite as hard, right? Because the balloon is all stretched out now. It's much more compliant, right? So when the balloon is brand new, it's kind of non-compliant, and once it's already been inflated, then it's much more compliant, so you don't have to work so hard to inflate it. So lung compliance is similar to that. When your lungs are compliant, that means it's easy to inflate your lungs. When your lungs are non-compliant, it's much harder to inflate. Okay, so now let's think of some things that might make your lungs harder to inflate or less compliant. What if you have a lot of scar tissue or fibrosis in your lungs? You know, scar tissue is not as elastic as lung tissue, so it's going to be harder to inflate. Or what if you have pulmonary edema? You know, if there's a lot of fluid in your lungs, fluid is heavy, and so it's going to be harder to make your lungs inflate. Or if you don't have surfactant, right? Surfactant is supposed to help you overcome surface tension. Surface tension is that thing that makes your alveoli want to collapse. If you don't have surfactant, you can't overcome surface tension. That's going to make it just that much harder to expand your alveoli. Does that make sense? So you would think, wouldn't you, that the more compliant your lungs are, the better off you are? Well, that's not true, because there is such a thing as having lungs that are too compliant. There are some diseases that cause your lung tissue to lose its elastic recoil. The lung tissue becomes like a piece of elastic that gets all stretched out. So it's easy to inflate, but because it doesn't have that elastic recoil, it's hard to deflate. So you see in this picture on the left, we have elastic recoil that's helping exhale the air. And in the picture on the right, that alveoli has lost its elastic recoil, so now it's hard to deflate the lung. And the problem with that is, you know, if you don't exhale the old deoxygenated air, can you get fresh, new oxygenated air in to take its place? No. Okay, so you don't want lungs that are non-compliant. You don't want lungs that are too compliant. You want a nice, happy medium. All right, the last thing that affects the movement of air in and out of the lungs is airway resistance. And airway resistance is just the resistance that the air encounters as it tries to move through your airways. So you probably remember from physics or something like that, that as the air tries to move through the airways, it does encounter friction and some other forces like that. But really, the primary thing that determines how much resistance the air is going to meet is the diameter of the airway. The smaller the diameter of the airway, the more resistance there is to the air moving through it. So the smaller the airway, the harder a person has to work in order to move the air through the airway. So here's a little analogy I always use to illustrate that. Okay, so I have two straws, right? I have a big fat boba straw, and then I have a little skinny coffee stir stick. But, you know, there's a hole in it, so you can use it as a straw if you want to. Okay, so let's say somebody's chasing me, right? And I'm running away, and I run past a pond, and I get this bright idea that I'm going to jump into the pond and hide under the water, and I'm going to stick one of these straws out into the air so I can breathe through it until the person who's chasing me runs past the pond. Okay, so which straw am I going to want to breathe through? The big fat one, right? Why? Because I won't have to work so hard to move enough air through that big fat straw to, make sure I get enough oxygen. If I tried to breathe through that little skinny straw, I'd have to work a lot harder to make sure I got enough oxygen so that I didn't die, right? So the reason I don't have to work as hard to get air through that big fat straw is because there's less airway resistance. The air moves much more easily through it. I can move a large volume of air much more quickly. Does that make sense? So because we know now that airway resistance is lower when the airways are larger, it makes sense then, doesn't it, that resistance is always less when you inhale than when you exhale, right? Because when you inhale, the size of your chest cavity gets bigger, that pulls your airways open wider, and so there's less resistance. You can move air more easily through your airways. When you exhale, the size of your chest cavity gets smaller and it kind of compresses your airways so they get narrower. So there's always more resistance in your airways when you exhale than when you inhale. Okay, that explains why people who have any degree of airway constriction, like maybe somebody who has asthma, they're going to have just as much trouble exhaling as they will inhaling, right? Because, when we think of somebody having airway constriction and an asthma attack, we usually think, oh, they're having trouble getting air into their lungs, right? But remember, your airways are always narrower when you exhale, meaning the resistance is higher when you exhale. And so those people with airway constriction, they're going to have just as much trouble moving the old air out of their lungs as they have getting new air in. Right? And remember, the problem with not being able to get your old air out is if you don't get your old deoxygenated air out of your lungs, can you get fresh oxygenated air in to take its place? No. Okay, so remember, when you have people with airway constriction problems, look at not just inhalation, but exhalation issues. Does that make sense? Ooh, one last thing I almost forgot to say. Keep in mind that children have smaller airways than adults do, right? So their airways are always narrower. They always have a little bit more airway resistance than adults and always have to work a little bit harder than adults do to move air in and out of their lungs. So, does it make sense now why kids get into respiratory trouble a lot quicker than adults do? Yeah, so let's think about maybe a toddler who has croup, if you've ever seen a baby with croup, right? Their airways get constricted and you can hear them wheezing, right? Wheezing is the sound of air moving through very narrow airways. Okay, so if you had a baby or a toddler that was wheezing, okay, you could hear them audibly wheezing even without a stethoscope. Okay, would you be more worried if you heard them wheeze when they inhaled or wheeze when they exhaled? I would be more worried if I heard them wheeze when they inhaled, right? Because remember, your airways are supposed to always be wider when you inhale than when you exhale. And if they're wheezing even when they inhale, then they're probably in pretty bad trouble, right? If they wheezed only when they exhale and not when they inhale, then it's not so bad. But if they're wheezing on both inhalation and exhalation, this person is in more serious trouble. Okay, now that we've got the air in and out of our lungs, let's talk about gas exchange. Because even if you get the air in and out of your lungs, that doesn't help you any if gas exchange doesn't take place once you've inhaled, right? So, there are three processes involved in gas exchange. We have ventilation, perfusion, and diffusion. Okay, so ventilation is moving the air into and out of the alveoli. Perfusion is having the blood flow through the pulmonary capillaries, ready to participate in gas exchange. And then diffusion is the actual movement of oxygen and carbon dioxide across that alveolar capillary membrane. So basically, you have to have air going in and out of that alveolus. That's the ventilation piece. You have to have blood flowing through that pulmonary capillary. That's the perfusion piece. And then you have to have the oxygen and the carbon dioxide actually diffusing across that alveolar capillary membrane. Does that make sense? Okay. Now, a lot of times people get confused between which is the ventilation piece, which is the perfusion piece. And this is the analogy that I give them to help them remember it. Okay, so if you're going to buy a new house and you're checking out the ventilation system of that house, are you checking out the movement of air through that house, or are you checking out the movement of blood through that house? The air, right? The ventilation system is talking about the movement of air through the house. So ventilation involved in gas exchange, we're talking about the air part of gas exchange. Does that make sense? Okay, so there are actually three things that affect how much gas is actually going to diffuse across that alveolar capillary membrane. Those three things are the partial pressure of the gases, the surface area that's available for gas exchange to take place across, and the thickness of that alveolar capillary membrane. Okay, let's talk about each of those three, starting with partial pressure. All right, so let's set the stage first. So you remember that room air is not just one kind of gas, right? Room air is made up of a mixture of a lot of different gases. And each of the gases in room air contributes to total atmospheric pressure. So the partial pressure of a gas is just that part of total atmospheric pressure that's due to the presence of that gas in room air. So the partial pressure of oxygen is just that portion of total atmospheric pressure that's due to the presence of oxygen in room air. And the partial pressure of carbon dioxide is just that part of total atmospheric pressure that's due to the presence of carbon dioxide in room air. And if you were to add up all the partial pressures of all the gases in room air, you would get total atmospheric pressure. So this is an illustration of how if you add together all the partial pressures of all the gases in room air, you get total atmospheric pressure. Okay, but if that doesn't make any sense to you, that's okay, because all you really need to do is to remember that gases are always going to diffuse from areas of higher partial pressure to lower partial pressure. Okay, gases always diffuse from areas of higher partial pressure to lower partial pressure. And the bigger the difference between those pressures, the bigger the gradient is, the more gas is going to diffuse. Now, if we go back to this picture, the partial pressure of oxygen in the alveolus is greater than the partial pressure of oxygen in the venous blood that's going through that pulmonary capillary. So the oxygen is going to diffuse from the alveolus into the venous blood. The carbon dioxide is going to diffuse in the opposite direction because the partial pressure of carbon dioxide in the venous blood is greater than the partial pressure of carbon dioxide in the alveolus. Now, remember we said the bigger the gradient, the bigger the difference between the partial pressure of the gas in those two locations, the more gas is going to diffuse. That's the reason why if we want to move more oxygen into the blood, we will give people extra oxygen to breathe. You know, if we use oxygen masks or a nasal cannula and give people extra oxygen to breathe, that means the partial pressure of oxygen in the alveolus is going to be even greater than it was before. And so more oxygen is going to diffuse into the blood. Does that make sense? All right, the second thing that affects how much gas is going to diffuse across the alveolar capillary membrane is the surface area of that membrane. So somebody actually calculated out how much surface area there is available in all the alveolar capillary membranes in your lungs. And apparently it turns out to be about equivalent to the size of a tennis court. Okay, so that's a lot of surface area. And the more surface area you have, the better off you are, because that allows for more gases to diffuse. If you have some kind of disease that destroys that alveolar capillary membrane, or if you have surgery and have part of your lung removed, okay, that is definitely going to cut back on the amount of surface area there is available, and therefore there is going to be less gas diffusing across that membrane. The last thing that affects the amount of gas that's going to diffuse across that alveolar capillary membrane is the thickness of the membrane. The thicker that membrane is, the less gas is going to be able to diffuse across it. So if you have a disease that causes swelling of that membrane, like maybe an infection, then that membrane is going to be thicker, less gas is going to be able to cross it. Or maybe if somebody has scar tissue buildup in their lungs, that might thicken the membrane, less gas is going to be able to cross. So bottom line is, the thicker the membrane, the less gas exchange, the worse the patient's oxygenation is going to be. Now, one thing we like to see in order to have the most efficient gas exchange is we like to see a nice match between the ventilation and the perfusion. We don't want to waste any of our resources, so we don't want to waste any of the ventilation or any of the perfusion where it can't be used. There are actually two types of ventilation-perfusion mismatches that can occur. We can have perfusion without ventilation and ventilation without perfusion. Okay, now if you look at this picture, the airway in the center is what normal should be. Okay, so we have air flowing freely into that alveolus, and we have blood flowing freely through that pulmonary capillary that surrounds the alveolus. So we have our ventilation and our perfusion nicely matched. On the left side of that diagram, you see the first kind of mismatch, perfusion without ventilation. Okay, so what we have are areas of the lungs that are being perfused. The blood is going through those pulmonary capillaries, but it's not being ventilated. And this is something that can occur like if you get an airway obstruction or something. So you see in the picture on the left, there's a big round black thing that's occluding the airway. Okay, so the perfusion is there, but the ventilation is impaired. When that happens, we call it a shunt, because what's happening is that the blood is being shunted from the venous circulation to the arterial circulation without having picked up oxygen first. Okay, the blood is being shunted from the venous circulation to the arterial circulation without having picked up oxygen first. So you see in that situation, we're basically wasting perfusion, right? We've got blood that went to the lungs but was not able to pick up oxygen or participate in gas exchange. The other kind of ventilation perfusion mismatch is when you have ventilation without perfusion. So if you look on the right side of this diagram, that's ventilation without perfusion. You see that the air is going into the alveoli very freely, but there's an obstruction in the pulmonary capillary, and that's preventing perfusion. There's no blood flowing through that pulmonary capillary. Again, that is not conducive to good gas exchange. When that happens, we call it dead airspace, because even though the air is there in the alveolus, it's basically dead, right? Because there's no blood coming through, and so it can't participate in gas exchange. A good example of dead airspace is a pulmonary embolism. A pulmonary embolism is an obstruction in a branch of the pulmonary artery, and so now there's no perfusion coming into that part of the lung, right? So we have ventilation, but we don't have perfusion. One of the most common causes of pulmonary embolism is a DVT that gets knocked loose from its position in the leg vein and then travels back to the heart and gets pumped to the lungs and gets stuck in an artery in the lungs. So we might expect to see poor gas exchange, right? Because remember, it is a ventilation perfusion mismatch. So we're going to see the hypoxia, the shortness of breath, the fast breathing, fast heart rate that you get when there's hypoxia. And there might also be some ischemia in the lungs, some actual damage to the lung tissue, because, if we're cutting off blood flow to a part of the lung, then there might be some ischemic damage. Because of that potential damage, there might be some inflammation present. People might complain of pleuritic chest pain. They might have, a slight fever. But the symptoms are actually going to depend on how big the pulmonary embolus actually is. Sometimes clots are really tiny and people may not even notice that they had one. Sometimes we don't even know people had a pulmonary embolism until, when they finally die and we do an autopsy on them, we can see where some lung tissue was damaged and we're like, oh, this person had some pulmonary emboli, but it never showed up in their past medical history. Other pulmonary emboli are big, like the one in this picture. Look at how long it is. I mean, it looks almost like a blood vessel because it was so long, it took up so much space. A pulmonary embolus that big can really cause a lot of tissue damage in the lung because of the ischemia that it causes. We might see people just kind of go into shock and die. So a lot of times we hear about people who took a long plane ride, it was an international flight and maybe it took 15 or 18 hours to go around the world, and they were immobile basically for that length of time. And so then they get a DVT in their leg, and then when they get off the plane and they start walking, that walking movement knocks the clot loose and it starts to travel, and then they have a pulmonary embolus. So the next time you take a long plane ride, make sure you do like little stationary leg exercises to use your skeletal muscle pumps so that you're not going to get a DVT and you don't end up with a pulmonary embolus. Oh, I forgot I was going to talk about interventions. Okay, so we do have the option to try and surgically remove a pulmonary embolus. You see here in this picture, they've done an embolectomy. Okay, they've actually removed the clot. Not everybody is a good surgical risk. So we have other options, like we might do thrombolytic therapy, trying to break down the clot. A clot this big, thrombolytic drugs might not be as effective. But, if it's a smaller clot, we could try thrombolytic drugs followed by anticoagulants to try and prevent clots from recurring. Okay, now that we've got the air in and out of our lungs and we've got the oxygen from our lungs into our blood, now we need to talk about how that oxygen is going to get to the tissues. And we need to talk about how carbon dioxide gets from the tissues back to the lungs so it can be exhaled. That gas transport occurs through the blood. Let's talk about oxygen transport first. Oxygen can travel in the blood in two forms. It can travel dissolved in the blood, and that's what we're looking at when we measure somebody's PO2, or the partial pressure of oxygen in their blood. We're measuring how much oxygen is traveling dissolved in the blood. The other way oxygen can travel is attached to hemoglobin. And when we look at somebody's O2 saturation, or SaO2, What we're measuring is how much of that person's hemoglobin is actually carrying oxygen. So when we look at O2 saturation, we're actually looking at how much of the oxygen is traveling attached to hemoglobin. Now, the large majority, about 98 to 99% of the oxygen in your blood is traveling attached to hemoglobin. Only about 1% of the oxygen in your blood is traveling dissolved in your blood. But this is a very important 1% because that is the only oxygen that can leave the blood, enter the cells, and have the cells use it. Okay, oxygen that's attached to hemoglobin is kind of stuck in the blood vessel. It can't leave. Oxygen that's dissolved in the blood can leave the blood vessel, go into your cells, and your cells can use it to make ATP. So basically, the oxygen that's attached to hemoglobin is sort of like in storage, right? So the cells use the cells use the oxygen that's dissolved in the blood, and as the cells use the oxygen that's dissolved in the blood, the PO2 starts to drop. When the PO2 drops too low, then the hemoglobin is going to say, oh, I need to bring that PO2 back up, and so it's going to start releasing some of the oxygen that it's carrying. So the oxygen is sort of stored by the hemoglobin until the PO2 starts to drop, at which point the hemoglobin is going to start releasing its oxygen, and that brings the PO2 back up. Does that make sense? Now, under normal circumstances, hemoglobin is going to start releasing its oxygen when the PO2 drops to about 60. Now, there are some conditions that might cause hemoglobin to release oxygen sooner. Like maybe it'll start releasing oxygen when the PO2 gets to 80 instead of waiting all the way until it gets to 60. In those situations, we say that hemoglobin has a decreased affinity for oxygen. It's releasing the oxygen sooner. Affinity just means attraction. Okay, so when hemoglobin has a decreased affinity for oxygen, that means it's not as attracted to the oxygen, it's willing to release it sooner. Okay, so there are some conditions that cause hemoglobin to release oxygen sooner, some conditions that cause hemoglobin to hang on to oxygen longer. Let's talk first about when hemoglobin is going to release oxygen sooner. Hemoglobin will release oxygen sooner when there's more acid present, more carbon dioxide, and more heat. And the reason why is because acid, carbon dioxide, and heat are all byproducts of metabolism, right? When cells burn fuel using oxygen to produce ATP, the waste products are acid, carbon dioxide, and heat. So when there's a lot of those three things present, the hemoglobin knows that there's a lot of metabolism going on. And because metabolism requires oxygen, hemoglobin is going to start releasing oxygen sooner so it can support the metabolism and keep it going. Does that make sense? Now remember, there are also some conditions that cause hemoglobin to hang on to oxygen longer. Instead of releasing oxygen when the PO2 gets to 60, it might wait until the PO2 drops all the way to 40 before it starts releasing oxygen. As you might imagine, the conditions that make hemoglobin hang on to oxygen longer are the opposite of what makes it release oxygen sooner. Hemoglobin will hang on to oxygen longer when there's less acid present, less carbon dioxide, and less heat. Because when there's less of those three things around, hemoglobin knows that there's not that much metabolism going on. So the body really doesn't need all that much extra oxygen, so the hemoglobin decides to hang on to the oxygen longer to save it for a time when maybe the body would need it more. What about how carbon dioxide travels in the blood? Carbon dioxide can actually travel in three forms. First, it can travel dissolved in the blood. That's what we're measuring when we measure the PCO2, or the partial pressure of carbon dioxide in the blood. and about 10% of the carbon dioxide does travel in that form. Carbon dioxide can also travel attached to hemoglobin, and about 30% of the carbon dioxide travels in that form. Once the carbon dioxide gets to the lungs, the hemoglobin releases it, and then it can be exhaled. Then the hemoglobin will turn around and pick up oxygen. Okay, the majority of the carbon dioxide in the blood, though, is going to travel in the form of bicarb. About 60% of the carbon dioxide actually travels in the form of bicarb. Now, there is an equation that kind of summarizes how this process works, and here it is. Now, let me explain to you what I want you to think when you see this equation. Okay, so carbon dioxide diffuses into a red blood cell where it combines with water and becomes carbonic acid. The carbonic acid can then easily ionize out into hydrogen ions and bicarb. And at that point, the bicarb will diffuse back into the blood, and the kidneys can either save it or get rid of it in the urine, depending on what you need in order to keep you in acid-base balance. Now, the really cool thing about this equation is it shows you that the body can take a waste product like carbon dioxide and change it into something that it can actually use to keep you in acid-base balance. Isn't that cool? So that's how oxygen and carbon dioxide move back and forth between the lungs and the tissues. Now, if anything goes wrong with any of the steps that we covered so far, what were the two problems we said were going to happen? Okay, if something goes wrong with gas exchange, you're going to have hypoxia and hypercapnia. Let's talk about hypoxia first. Okay, I want to point out to you that hypoxia and ischemia are not the same thing, right? Hypoxia means there's not enough oxygen to the tissues. Ischemia means there's not enough blood flow to the tissues. Now, of course, if you're not getting enough blood flow to the tissues, you're not going to be getting enough oxygen either, right? So ischemia can cause hypoxia, but can you see how you can have hypoxia without having ischemia? For example, let's say somebody has atelectasis and a bunch of their alveoli have collapsed. Can you see how that's going to interfere with getting oxygen to the tissues without causing any problems in blood flow? Right? So just keep in mind those two things are not the same. Also, with ischemia, if you're not getting enough blood to the tissues, you're also not getting enough glucose to the tissues, and you're going to have trouble getting rid of the waste. So it's not just an oxygen problem with ischemia, it's also glucose and waste products that are issues. With hypoxia, we're just really worried about the oxygen. Does that make sense? All right, symptoms of hypoxia. There are a lot of them, so what I'm going to do is I'm going to break them into two main categories: sympathetic nervous system symptoms and central nervous system symptoms. Because, I think it's easier to remember all of them when you only have two groups of symptoms to remember instead of a whole bunch. So this is like a memory trick. Okay, first of all, we have sympathetic nervous system symptoms. When you're not getting enough oxygen, your body does interpret this as a crisis, and so it's going to activate the sympathetic fight or flight mechanism. So, what are the symptoms of sympathetic stimulation? Tachycardia, pale, cool, clammy skin, anxiety, okay? Those are the things that you're going to see fairly quickly when somebody becomes hypoxic. The second group of symptoms that are associated with hypoxia are central nervous system symptoms, because your brain is highly dependent on oxygen in order to produce ATP. So when your brain isn't getting enough oxygen, you're going to start seeing some changes in neurological function. Okay, what you're going to see is going to depend on how hypoxic the person is. If it's just slight hypoxia, you're going to see people maybe not thinking very clearly. As it gets worse, then they might start getting restless or a little agitated. They might start acting differently than they usually do. Their judgment is going to become impaired. As the hypoxia gets even worse, then you might start seeing people have trouble with coordination, or they might get confused or delirious. And worst case scenario, when the hypoxia is really bad, people might actually fall into a coma. So here's just a little mnemonic thing that I found on Google Images that might help you to remember, the three things that are listed in this mnemonic actually reflect both sympathetic and central nervous system symptoms. Now, interestingly enough, if you ask most non-healthcare people what they think the symptoms of not having enough oxygen are, one of the first things they're going to say is, oh, the person's going to turn blue. Okay, in other words, they're going to become cyanotic. But cyanosis is usually a fairly late sign of hypoxia. We don't want to wait until our patient turns blue to be able to figure out that they're hypoxic. That's the reason we want to look for those other kinds of symptoms, because those are the ones that are going to show up first. Okay, the other thing I want to say about hypoxia is notice that when you check capillary refill, you are not checking oxygenation, right? What are you checking when you check capillary refill? You're checking circulation, right? So on the test, please don't tell me that you're going to assess somebody's oxygen status by checking their capillary refill, okay? What about hypercapnia? What are the symptoms of having too much carbon dioxide in the blood? One of the more common things that we see is what we call CO2 narcosis. Okay, now the root narco means sleep, right? Narcolepsy is a sleep disorder. Narcotics make you sleepy. Okay, so CO2 narcosis means the person usually gets progressively sleepy. And as the hypercapnia gets worse, they're going to start becoming disoriented and may eventually fall into a coma. Now, if the symptoms of hypoxia and hypercapnia sound similar, that actually makes sense, right? Because when you have poor gas exchange, you usually get both hypoxia and hypercapnia, right? Now, when the hypoxia and the hypercapnia get severe, we call it respiratory failure. Now, notice that respiratory failure does not mean that the patient has stopped breathing, right? That would be respiratory arrest. When we say respiratory failure, we mean that the patient is breathing, but their lungs are failing to adequately oxygenate the blood or remove the carbon dioxide. Now, respiratory failure is not a specific disease, but more a condition that can occur with several different kinds of respiratory disorders. In fact, pretty much all of the respiratory diseases that we're going to talk about next class period, if they get bad enough, can end up causing respiratory failure. As a general rule, when someone's PO2 drops below 50 and their PCO2 rises above 50, that's when we usually consider them to be in respiratory failure. But these numbers really are only valid for people with acute respiratory problems. In people with chronic lung disorders, remember, chronic lung disorders occur more gradually over a longer period of time, and because of that longer period of time, the patient has time to get used to having abnormal PO2 and PCO2 levels. And so they might have numbers that look like this, and they might be sitting there alert, talking with you, not in any acute distress. However, if you have a patient whose numbers look this way and it got that way over a fairly short period of time, they wouldn't have had time to get used to having high PCO2s and things like that. And so those people are going to look in acute distress. Okay, so the moral of this story is you have to look at your patient Don't just look at the numbers. The last thing we need to talk about today is how breathing is regulated. Primarily, breathing is controlled through the nervous system. And the main control center is called the respiratory center. It's located in the pons and medulla there in the brainstem. And there you can see parts of it. And don't worry, I don't expect you to know all of these different names. I'm just showing you this picture so that you have an idea of where the respiratory center is located. Now, the respiratory center provides continuous input to your respiratory muscles. And actually, one of the signs of brainstem injury is very irregular breathing patterns. Now, I'm sure you're aware that there are two components to the control of breathing. There's an automatic one and there's a voluntary one. Okay? The automatic regulation is based on input from several different kinds of receptors in your body. You have chemoreceptors in places like your medulla and in some of your major arteries like your carotid or your aorta. And these chemoreceptors are monitoring things like the level of oxygen or carbon dioxide in your blood, the pH of your blood, and it's sending that information to your respiratory center to help the respiratory center adjust your breathing to meet the changing needs of your body, to keep those things that it's monitoring within normal limits. You also have a lot of receptors in your lungs that are going to send information to the respiratory center about things like the airway pressure in your lungs, how much the lung tissue is being stretched or inflated, whether there's congestion or irritation in the lungs. And the respiratory center uses that information to make adjustments in the person's breathing to protect the lungs and to decrease how much effort it takes to breathe. But I'm sure you're all aware that there's also a voluntary component to the regulation of breathing, right? Because you all know that you can hold your breath when you want to, right? And, you kind of have to if you're going to do things like sing or play a musical instrument, swim, or, blow up a balloon or something like that. The voluntary component of breathing regulation is like an override feature because, the automatic regulation of breathing occurs in what we call a lower brain center. The brainstem is considered a lower brain center. If you want to override that automatic regulation, you have to use a higher brain center. By that, we're talking about like your cerebral cortex or your cerebrum, right? So you can voluntarily override the automatic regulation if you use a higher brain center. The only other part of the nervous system that's involved in regulating breathing is the autonomic nervous system. You remember this is the system that we divide into the sympathetic versus parasympathetic divisions. The autonomic nervous system is really only involved in breathing in terms of controlling the diameter of your airway. Okay, so when you have sympathetic stimulation, do you think your airways are going to bronchoconstrict or bronchodilate? Sympathetic stimulation is going to bronchodilate you, right? Because remember, the sympathetic stimulation is the fight or flight reaction. And if you're going to fight or run away, you have to have oxygen to do that. And so we're going to dilate your airways to make sure you have the oxygen you need. The parasympathetic stimulation is going to do the opposite. It's going to cause bronchoconstriction. Does that make sense? All right, that's it for now. I will see you in class. Bye.